So thank you all for joining us today for Daria. We haven't done a journal club in a little while, which, well, on the one hand, is because we've had so many interesting presenters from here, there, and everywhere, but also, but nonetheless, it's important that every now and then we have a look at what is new in the literature and something that is of relevance and interest. And somebody brought this paper to my attention a little while ago, and I was hoping we could ask one of our lovely registrars to go through it and have a bit of a chat about it. So without further ado, we've got Ryan Coker here, who's our advanced trainee in addiction psychiatry at St. Vincent's Hospital Alcohol and Drug Service, and he's working actually also on a research project looking at the relationship between psychological well-being and social support among people with methamphetamine use disorder. But on this occasion, he's going to be presenting this paper around Baclofen, and its efficacy in preventing relapse in GHB-dependent patients. So take it away, Ryan.
Cheers. Thank you so much, Chris. So hi, everyone. Thank you so much for coming today. As Chris said, my name's Ryan. I'm one of the addiction psychiatry registrars here. And today we're going to be having a look at a really, really interesting paper that I really enjoyed reading. Thanks to Chris, who recommended it, which is looking at a case-controlled study looking at Baclofen to prevent relapse in GHB-dependent patients. I'd like to start off, though, by acknowledging the Gadigal people, the traditional custodians on the land on which I currently am, and I guess on which we meet today. And I'd like to pay my respects to their elders past, present and emerging. And I extend that respect to any Aboriginal or Torres Strait Islander people who may be here today. For what we're going to be doing today, so we're going to be having a look at the paper. So we're going to be looking at the bit of the background to GHB and Baclofen, a little bit about their introduction. We're going to have a look at the way that they ran the trial and the analyses and some of the intricacies within there. A little bit about the results, which I found to be really, really interesting, and also a bit about the implications and a couple of points that I was thinking about as we were reading through the paper. And you'll have to put up with some really, really badly added pictures. Unfortunately, PowerPoint sometimes lets you make these really, really cool things, but this one didn't. So let's jump into the background and look at the introduction to the paper. So GHB is a party drug that really emerged in the 1990s onto the party scene. My understanding is that it often came into the rave scene a little bit. So a lot of people, when they may have had techno or house parties, that was used there. And it was particularly seen within certain population groups, such as the MSM population group and a few others as well. Initially, it was seen as being quite innocent, but over time, we've started to realise that it's quite addictive, and it's also can be quite a dangerous substance as well. The data included in the paper is data about the prevalence within Europe. And they kind of said, look, there's not a lot of systematic surveillance of use of GHB within Europe, but there is a suggestion that use has increased over the last decade. The Australian statistics, which weren't in the paper, but which we do have data on, is that about 1% of the Australian population have used GHB throughout their life, and about 1 in 1,000 people use GHB each year. And GHB itself is short for gamma hydroxybutyrate. It's a short-chain fatty acid that's derived from GABA, which is the main inhibitory neurotransmitter within the brain. It binds to the GABA-A, the GABA-B, and the GHB receptors. And it's something that actually occurs naturally within the brain. It's particularly found within the hypothalamus and within the basal ganglia. And there are several other products that people use as well. There's GBL and 1,3-G something, I can't remember it off the top of my head. And these products are precursors to GHB, which can be broken down within the bloodstream to GHB. And sometimes they're used when there are restrictions on GHB availability within the population. And for anyone who's really, really nerdy about neurotransmitters like I am, this is a little bit about the metabolism of GHB. So as you can see, GABA, I'm not sure if you can see my mouse there actually, but GABA through a different pathway can become GHB and sort of vice versa. And GHB can be broken down and is partially renally excreted. So the recreational effects of GHB include euphoria, anxiolysis. So if someone's feeling quite stressed out or quite worried about something, it can help to bring their stress levels down. And it also causes a lot of disinhibition as well. It's got quite a more therapeutic index. I'm not quite sure if therapeutic is the right word for this, but it also carries a very, very high risk of respiratory depression, coma, and death. And I've asked a lot of patients sort of what it's like taking GHB and how they feel about the risk that is associated with it. And what a lot of people have told me is that it's so incredibly easy to overdose. That 1 or 2 meals, they may be feeling very, very wonderful, getting all the effects that they desire. But if they take 1 more meal, or even just half a meal, that it can quickly turn for them from a very enjoyable experience into something that can be quite drastically, potentially leading to needing to call an ambulance or go to hospital for that as well. And certainly, we know that this risk increases if it's combined with other substances, and especially substances that may act on the GABAergic system as well. So that includes things such as alcohol and benzodiazepines. GHB has a fairly rapid onset of action after ingestion, so it takes about 20 to 60 minutes to kick in. And it's got a very, very short half-life as well. So it often lasts only about 30 to 60 minutes. So back many, many years ago in a past life, before I started to be a psych-reg, I used to do a lot of work as a doctor at things like music festivals and nightclubs and stuff like that. It was actually really interesting. One thing that I noted that we'd see a lot of people who had overdosed on GHB, and sometimes we get very, very worried about them that they may not be breathing, or they may be breathing, maybe 4 to 6 breaths per minute. They may be completely unresponsive, very floppy. So it was almost like carrying a bit of a dead weight. And we get very worried about them. We call an ambulance, but by the time the ambulance had arrived to collect them and take them off to hospital, that they were actually up and bouncing around and, really didn't want to have anything to do with the ambulance and just wanted to get back to the party again. So GHB, as well as being quite dangerous when someone uses it, it can also have quite a lot of significant withdrawal symptoms as well. So mild, moderate withdrawal symptoms can include things like anxiety, insomnia, tachycardia, hypertension, and also a tremor as well. And from the cases I've seen, there tends to be a sooner onset than other substances such as alcohol, but often seems to be a little bit more intense, but over a shorter period of time. There's also the potential for quite serious withdrawal symptoms as well, and these can include things such as seizures, agitation, delirium, perceptual disturbances, including both visual and auditory hallucinations. And for some people, having a very severe withdrawal that may also incorporate a component of physical compromise. If someone may not be eating or drinking, it can also lead to coma, and it can sadly, in some cases, lead to death as well. And the mainstay of treatment for GHB withdrawal includes diazepam, and often very high doses of diazepam, and also Baclofen has started to work its way into protocols, including the protocol at St. Vincent's Hospital here. So what is Baclofen? So Baclofen is an agent that is a high affinity agonist for GABA-B receptors. So unlike benzodiazepines that primarily work on GABA-A receptors, Baclofen primarily works on GABA-B receptors. Compared to GHB, it's got a longer half-life. It's still shorter than a lot of medications that we may use, such as diazepam, but it means that we can use less frequent dosing, so 3 times per day rather than 12 times per day. And it also means that we can get more stable drug plasma levels. There's controversial evidence as an anti-craving agent in alcohol use disorder. I remember I read through this about 18 months ago, and there's a lot of sort of speculation about that. But it is something which does seem to be used primarily within the private sector as an anti-craving agent. There's also limited evidence for Baclofen promoting abstinence from GHB. So there's been one animal study which found that when mouse were administered GHB and they were given the option to self-administer, were given Baclofen and given the option to self-administer GHB, that it reduced the self-administration rate of GHB. And there's another case series which demonstrated that in participants having doses of 30 to 60 milligrams of Baclofen per day, that 9 out of 11 cases demonstrated abstinence at the 3-month mark. So we'll have a little look at the methods of the paper, of the study. And just in terms of terminology and everything like that, I'm just going to use the terminology that's within the paper here. So the study was a multi-center trial that was run across 6 addiction care facilities within the Nordic region. It was a case control study, and as part of that, it was open label, so it was unblinded, so both the participants and the researchers knew who was receiving Baclofen and who was not receiving Baclofen, and there wasn't a placebo agent involved. It was non-randomized, and as far as I can tell from the paper, the participants essentially elected to take the Baclofen or elected not to take the Baclofen. And obviously, as a trial, it had the appropriate ethics approval. So participants were recruited when they were admitted for inpatient GHB withdrawal management. So they're all people who had come to the addiction centre to receive medical withdrawal management from GHB, and then were given the option about whether they wanted to enrol into this trial to look at whether Baclofen could help with the abstinence down the track. Participants had to be aged 18 to 40, and they had to be classed as being GHB dependent as per DSM-4 criteria. And all participants had to have the goal for full abstinence, and they had to agree for outpatient follow-up and what could be seen as sort of more intensive outpatient follow-up, including weekly reviews by one of the researchers or physicians attached to the trial. There were a number of exclusion criteria, and I quite like these, especially the physical contraindications, because they laid it out quite nicely. So anyone who had a physical contraindication to Baclofen wasn't eligible to participate. And this included participants who may have significant liver or renal impairment, participants with hypertension, participants with diabetes, those who may have a pre-existing seizure disorder, or anyone who may be pregnant. Anyone with severe psychiatric conditions was excluded. And some of these made a lot of sense, like bipolar disorder or psychotic disorder. The major depressive disorder was an interesting one because I guess from a psychiatry perspective, we wouldn't consider it to be as severe as say, bipolar disorder or psychotic disorder. And there was an interesting outcome, which I'll talk about later. And anyone who was experiencing suicidal ideation was also excluded. Participants essentially had to be substance-free after withdrawal management. So any use of anxiolytics, stimulants, or hypnotics post-withdrawal management also, or between withdrawal management and enrolment into the study was an exclusion criteria, as was any previous misuse of Baclofen. And out of 137 patients who were admitted to the withdrawal facilities over the 6 centres and who were interested in joining the study, about 30 of them were excluded as a result of these criteria. There was a good section on the power analysis of the paper. So based on the effectiveness of Baclofen in alcohol use disorder, they based it on the effectiveness of Baclofen in alcohol use disorder, we saw abstinence rates reported to be as high as 70% if someone was taking Baclofen, compared to 20 to 30% with placebo. But they acknowledged that this was a controversial area within the literature. They anticipated a smaller effect in Baclofen dependence, so they anticipated that they may see 3 months abstinence rates of 60% on Baclofen compared to 40% for participants in the control group. And so they worked out that they needed to recruit at least 30 patients per group to detect any significant effects. Those who were on the treatment arm, which was the Baclofen intervention, and just keep in mind that people weren't randomized to this, they selected onto this, were initially commenced onto 15 milligrams per day of Baclofen, and this was 5 milligrams TDS. Over a 10-day period, this was titrated up to 45 milligrams, and if there were no side effects after 2 weeks, then this was increased to 60 milligrams per day. There was a total treatment course of about 14 weeks, which works out to be roughly 3 months, and there was weekly review with an addictions physician for the monitoring of adherence, any lapses or any relapses, any side effects, and one of the most important things that they were watching for was any signs of sedation. Because Baclofen, being a sedating agent, can be quite dangerous, especially if someone is oversedated from that. So everyone who was in the trial received treatment as usual. So those in the control arm just received treatment as usual. Those within the intervention arm or those receiving Baclofen also received treatment as usual on top of that. But this was not standardized between the centres, and it wasn't actually defined within the trial. So the trial suggested the treatment of usual would be cognitive behavioural therapy. It didn't talk about any particular components that may be part of that, such as, say, motivational interviewing, or whether it was cognitive behavioural therapy specific for substance use or just in general. But it also noted that participants may have additional treatment for any other social, psychiatric or medical problems that may come up. So for instance, if someone was having trouble with accommodation, that they'd be eligible to access some assistance with that. And the main outcome measures that were being measured was any lapses. So this was self-report of any use of GHB within the 3-month period. Any relapses, and this was self-report of GHB at least once per week during the 3-month trial. And also any patient who was unable to be contacted for follow-up was considered to have relapsed. And I thought this was quite interesting, and I'll tell you my thoughts about that a little bit later on. In addition to those outcome measures, there was also monitoring of any adverse effects. And they developed this really cool Baclofen side effects questionnaire, which had 21 points, each scored between 0 to 4. And items included things such as vomiting, nausea, diarrhea, depression, sedation, and things like that. Within the data analysis, so the demographics were analysed using descriptive statistics. And there was a comparison between the control group and the intervention group using ANOVA and chi-square tests. The primary outcomes were analysed in 2 ways. They were first analysed using an intention to treat analysis. So this looked at all participants receiving Baclofen and compared them to the control arm. The second way that this analysis was conducted was a per protocol analysis. So only participants who received Baclofen as per the protocol were compared to the control group. It was actually really interesting to see how few participants followed the protocol throughout the trial. Predominantly chi-square tests were used to conduct this analysis. And I found the results to be quite interesting. So first off, within the participants, so there were 137 participants who were identified as being potential candidates after their withdrawal management. Of those, 30 were excluded and 107 were included in the trial. From those 107, 37 participants received Baclofen and treatment as usual, and only 2 of those participants dropped out. But looking at the analysis at the end, only 12 of those participants actually received Baclofen as per the study protocol. The other 70 participants were enrolled in the treatment as usual arm, and they had a significantly higher dropout rate. So 15 participants dropped out from there, and only 55 participants were available for follow-up. So having a look at the demographics, so the demographics between the 2 groups, the control group and the intervention group, were actually quite similar. The only significant difference that was noted was within gender, in that more participants within the Baclofen group were male and less participants in the control group were male. But the authors commented about this, and they didn't think that gender would be considered a confounding variable, as it wasn't affecting treatment outcomes. One thing that also really jumped out at me from these results is the length of time that people were using GHB, and especially the number of months that people were using GHB daily. Because for some participants, it was between 2 to 3 years. And also it was at quite high doses as well. So anywhere up to, and this is just looking at the mean values, so not the actual range, but the mean was up to 55.6 grams per day, which is quite a high dose. And we can see as well that the average interval between dosing was under 2 hours. So a lot of the participants were using high doses of GHB for long periods of time, and they were having to dose very regularly as well. So I guess within any measure, we would consider that there'd be quite an established dependency there. Within looking at the outcomes from a intention to treat analysis, no difference was found between the two groups in terms of lapse or relapse rates for participants who completed follow-up. But if dropouts were counted as relapse, then there was a significantly lower rate of relapse within the group receiving Baclofen. And the numbers are over here. So there's quite a strong significance if we include participants who dropped out. The rate of relapse actually halves between the treatment of usual group and the group receiving Baclofen. If we look at the per protocol analysis, so these are a small number of participants who received Baclofen as per the agreed study protocol. So there was a significantly lower lapse of relapse within the Baclofen group, but there was no significant difference within lapse rates. And again, we can see from the numbers over here that not only is the association quite strong, but the effect size is quite large as well. But we're looking at only very, very tiny numbers. So we've only got one participant who was taking Baclofen who relapsed and two participants who relapsed. But this is only out of a total of, I think, 12 participants who were taking Baclofen. So it looks like there's quite a significant improvement in terms of the magnitude of the effect, but it's difficult to measure because we've only got very small numbers of people within the groups. In terms of the side effects, so there are actually quite limited side effects reported and no serious adverse events, which is very reassuring. The most frequently reported side effects were participants feeling tired, and that was about 1 in 4 participants. Feeling sleepy during the daytime, and that was about 1 in 7 participants. And also feeling depressed as well. So looking at the discussion and I guess the implications from the discussion onto further research and clinical practice. So this is the first case control study evaluating the effectiveness of Baclofen in GHB dependent patients. The authors said that their results are comparable with the earlier case series showing 81% abstinence at 3 months. And they noted that compared to alcohol dependence, where doses of up to 300 milligrams of Baclofen are prescribed per day, that they were able to achieve fairly good abstinence rates with quite low doses, so only 45 to 60 milligrams per day. They suggested that in terms of long-term treatment, that Baclofen could potentially act as a substitute treatment for GHB, similar, I guess, to what we may use Suboxone for in opioid dependence. But they did also acknowledge that it's impossible to draw any conclusions about long-term effects. They recognised that the study was only over a 3-month period, so it's impossible to know what the long-term benefits of taking Baclofen were, but also whether there could be any potential long-term harms from taking Baclofen. They acknowledged several limitations within the study, and they emphasised that the results needed to be interpreted with caution, given that this was not a double-blinded randomised control trial. It was non-randomised. The participants were eligible to select into which arm they wanted to, and also both the participants and also the researchers were not blinded. They acknowledged that their sample size was limited, and they said it was actually quite lower than what they anticipated. They were expecting to have at least 30 participants taking Baclofen as per protocol. And whilst they got 35 participants in the Baclofen arm who ended up going to the end of the trial, only 12 of those participants received the Baclofen as per protocol. They identified that patients who chose to take the Baclofen treatment may actually be more motivated to achieve full abstinence, and their level of motivation may potentially act as a bit of a confounding variable. And they also acknowledged that treatment as usual was not standardised across the sites, so there could be differences between the sites there, nor could they actually define what the treatment as usual approach was. Furthermore, they acknowledged that part of treatment as usual could be that patients may have been prescribed benzodiazepines. So as part of their normal treatment, be it to treat any prolonged withdrawal picture or to treat, any psychiatric symptom or anything like that. There was no requirement that patients not be prescribed benzodiazepines. So they may have been prescribed something such as Valium or alprazolam or something that could have confounded the results. Although I do note that when people were being selected for this trial, that had they had any benzodiazepines between their withdrawal management and the enrolment into the study, that they would have been excluded based on that. So it would have been after the enrolment into the study. They identified that abstinence was only based on self-report measures, and they acknowledged that it's sort of quite difficult to be able to objectively monitor whether someone has used GHB, because there's an incredibly narrow time frame for urine drug screens, blood tests, and things like that. And they also acknowledged that adherence was solely based on self-report measures. So ways of measuring this in other studies, such as pill counting by the addictions physician or something like that, was not implemented within this trial. Furthermore, this is something which actually really jumped out to me. They said that the side effects were not measured in the control group, and they were actually querying whether a lot of the side effects from the GHB-dependent patients could actually be the result of GHB withdrawal rather than the result of the Baclofen itself. So things such as, nausea or vomiting, or potentially even depression, that could be a more protracted GHB withdrawal picture rather than being the result of Baclofen. So they suggested that that could be something that could be monitored in future trials. They also identified that there's significant scope for future research into whether Baclofen may play a role in promoting abstinence from GHB. So they very strongly suggested that there should be a placebo-controlled, randomized, double-blind controlled trial performed looking at Baclofen. They identified that there's also a number of things that need to take place as well, including identification of what effective doses are, so whether 45 to 60 milligrams is the best dose, whether it may need to be more than that, as is seen in alcohol, or whether it could be less than that potentially. They suggested that there needs to be a close look at the safety data for particularly higher doses of Baclofen in GHB dependence. And I think that this is something which in my mind is very important, because certainly there's a very high risk if Baclofen is combined with other substances such as GHB, but also alcohol or benzodiazepines. There is quite a higher risk of over-sedation, of people having falls, of people having injuries, people potentially ending up in comas and things like that. And they also acknowledged that their study, being only over a 3-month window, couldn't be extrapolated to consider the long-term efficacy of Baclofen and GHB dependence. So they also suggested that, that a longer-term trial could be considered as well. But overall, the conclusion that they drew was that the study showed that Baclofen could be a potential candidate for preventing relapse in GHB-dependent patients after detoxification, or I guess what we in Australia would call medical withdrawal management, particularly when administered strictly according to the protocol. Though promising, future studies with a longer follow-up and a randomised double-blind design should be conducted to confirm these findings before recommendations for clinical practice can be made. So I found that this paper, I actually really enjoyed reading it. I thought that it made a lot of sense, and theoretically it makes a huge amount of sense to me that the Baclofen could play a very important role in the management of GHB dependence. But there were a few sort of thinking points that I just jotted down as I was going through the paper. The first of these points is, I guess, about the higher level of care that was received by the intervention group. So any participant who was receiving Baclofen got a weekly review by a physician, and it sounded like this was a fairly in-depth review where they were being asked about any lapses or any relapses, any side effects, about their adherence and things like that. And this is sort of quite intensive, and it could potentially provide a lot of support as well. Whereas the treatment as usual arm wasn't really defined, and it could be that people were also receiving very intensive weekly follow-up and group programs and lots of really wonderful interventions. It could also be that they may only be able to have a couple of sessions of CBT spaced several weeks apart. So I was wondering about whether the high level support for those in the Baclofen group could also be an alternative explanation for the reduced relapse rates. And certainly in my mind, if we in a perfect world have the capacity to offer our patients weekly counselling or weekly psychotherapy, I'm sure that we see, quite good relapse rates, quite good abstinent rates as well. Another thought that I was having is about the validity of sort of interpreting the lost to follow-up group as a relapse. Almost all of those who were lost to follow-up were in the control group. So I think it was 15 who were lost to follow-up was in the control group, and 2 who were lost to follow-up were in the intervention group. And going back to the first point, those in the control group potentially had a lot less contact with the service. There was no real incentive to remain in the trial. I couldn't see from the paper whether there was sort of any financial incentive or anything to participate. So certainly those who were in the Baclofen group had the incentive of continuing to receive the Baclofen. But whether the loss to follow-up were actual relapses or whether they were just people drifting away from the service without relapsing, I'm not too sure. And I was wondering about how valid it would be to assume that they were relapses. And also I was thinking about the characteristics of the cohort as a whole. That all participants appear quite motivated. All of them had attended inpatient withdrawal management. All of them were excluded if there were any substance use following the withdrawal management. And I know that there are actually much lower rates of relapse in the control group than what would be expected within a general population of people who may use GHB. So it also made me think as well about, sort of how much of the effect could have been because they could have been receiving sort of more counselling or psychosocial interventions. I guess the other thing as well about the Baclofen prescription is, as I said before, there's a much higher risk of overdose and in some cases death if someone uses GHB compared to alcohol. And certainly we recognise that there's quite a cumulative sedative effect from different substances. And it was quite interesting that from this study, and I think it was absolutely correct to do this, but users who may have any comorbid substance use of other substances were excluded. And I guess within my mind that it was very promising and very reassuring from this trial that there were no serious adverse effects, there were no sort of accidental overdoses or anything like that. I do wonder about whether that can be more generalized and whether in a general population of people who use people who use GHB, whether Baclofen will prove to be a safe option for use. And the other thing, and this is probably less from an addictions medicine perspective, more from a bit of a psychiatry perspective, is that we recognise that there's a very significant overlap between substance dependence and psychiatric comorbidities. And I did wonder whether this could be a bit underappreciated in this study, as participants who had a history of major depressive disorder were excluded. And the other thing as well was that quite a few participants who were in the Baclofen arm reported having depression. It was actually the 3rd most common side effect. So whether there could be a risk that Baclofen could precipitate or worsen a depressive episode is something which I think will require further exploration and potentially a lot of close monitoring. Because we certainly recognise, there's lots and lots of medications which can cause depression that when we stop them, people's depressive symptoms actually get better really, really quickly. So it will be interesting to see whether that's the case for Baclofen and whether it needs to be something that's monitored quite closely or whether it's something that can be quite safe, not just from an addictions medicine perspective, but also from a psychiatric perspective as well. And that brings me to the end. So thank you so much for listening. I hope that you enjoyed the paper as much as I did. And I'd love to hear what others' thoughts are.
Thank you very much, Ryan. I think you covered nicely all of the issues there. On your point around the dropouts being considered relapses, I would say that's probably fair enough. Perhaps, Nadine, you've got a bit more experience in this field. Would you consider them?
That'd be standard practice, I think.
Yeah, I would have thought that was fairly par for the course. I mean, most of the time when our patients come back to see us, they're usually one of two extremes. They've come back to see us because they've relapsed and they really need our help, and or they're sort of going really well and sort of perhaps at the point where you can discharge them to their GP.
I think that the point is, from a study perspective, it's a more conservative estimate of effect if you assume the people you've lost to follow-up are using, but we don't know because they're lost to follow-up.
The challenge here, though, I guess, is that you are offering some people something. And so it doesn't surprise me that the dropout rate was higher in the arm where psychotherapy is, of course, the mainstay of treatment for many substance dependencies, but many people won't perceive that as getting anything, so to speak. Whereas if you're getting Baclofen, you're getting something out of it. You're turning up, you're being given a medication that, and I hope wasn't being misused, but we don't know. So I guess it's not surprising, and so therefore, I guess there's the potential to maybe overstate the effect because patients are coming back. I don't know, just playing devil's advocate.
I've got a question. What's your opinion of the comparison group, Ryan? I actually, looking through the paper, I'm not clear how they even selected the comparison group. I guess, yeah. What you're critiquing the study? What's your opinion of the comparison group? And the second question is, you mentioned that there were quite a high number of people not taking the medication as planned. What's the the take home from that? What are the concerns around that in terms of its application for future practice, I guess? What were the reasons that people didn't take it as prescribed? Anyway, the first question is, what about the comparison group, so study design?
Absolutely. So my understanding from the reading of the paper, it's a little bit unclear, but my understanding from reading the paper is that the participants were sort of approached when they were inpatients going through the withdrawal management, and that they were sort of able to self-select into which group they wanted to be in. So participants who wanted to receive Baclofen were in the Baclofen group. Participants who didn't end up in the control group. I'm not 100% certain about that. It could have been actually a selection by whoever the treating physician was, or researchers, or things like that. But I think there was one sentence in there that made me think that there could have, that I think they said participants who chose to take Baclofen or something like that in the discussion. But it wasn't 100% clear to me how people got divided within the two groups.
So would that influence the results, do you think?
Absolutely, yeah. And they actually commented on that within the discussion, that participants who were in the Baclofen group potentially could have been more motivated, almost that there may have been a bit of I don't know if desperation is the right word, but I really, really want to stop GHB. I really want to not use it. So if there is a potential, even experimental treatment that could help me not to use it, that I'm going to be more likely to take it. And I think that they actually...
So there's a selection bias there that could perhaps suggest there's more likely to find a positive finding.
And given the patients, we often get patients crash landing with GHB withdrawal, and often many of them will just state straight out, "Oh, my dealer got arrested," and sometimes the arrested will even be in the cubicle next to them in the emergency department. So you probably do draw on a fair point there in that perhaps some of the people coming for withdrawal were coming for withdrawal out of necessity. Some were coming out of desire. So it's
I think the paper, though, does, to be eligible for the study, you had to be aiming for abstinence. I think that was already ticked off at the start, but just around the study design, what kind of selection bias might influence?
I guess that's why studies. I mean, we talked about the recent injectable naltrexone and bupropion for methamphetamine dependence, and they sort of got around that potential placebo effect by randomizing sort of twice, so to speak, with that second randomization. And maybe that's something that you could do in this, that it would be challenging because baclofen has a withdrawal effect and patients will probably know whether they are or aren't on it.
So, and then my second question about why such a surprisingly low adherence. Is there something wrong with the medication?
They just sort of specify why so few people were treated as per the protocol, at least not that I could see. Speculatively, I guess that there could be a few different reasons. It could be because it was run over a multi-site centre that things sort of fall between the cracks a little bit, appointments get cancelled or things like that. I guess it could be maybe potentially characteristics of those of the participants in the trial. Maybe people needed to take the baclofen every single day, but maybe missed a couple of days here and there. Maybe they immediately got moved into the not taking it as per protocol group. Yeah, I'm not 100% sure why.
So are you convinced sufficiently to then be involved in the next step, which is a multi-center randomized controlled trial? Are you convinced sufficiently that there's sufficient data to move to the next level or not?
That's a very good question. I'm sure that people a lot smarter and a lot more experienced than me may disagree. I thought it was very interesting. I thought that it would be really cool to see the next level trial to see if there's something which does help. I'm maybe more saying that more from a clinical perspective, in that it'll be really wonderful to see something. But I don't know, the results seem nice.
Nadine, are you torturing poor Ryan to sort of say we're all desperate for something to...
No, I'm because I mean this is looking at baclofen for relapse prevention. Baclofen has also been looked at for withdrawal, which are two different things. No, I'm curious to see the study design is a little opaque to me. I'm curious to know if Ryan thinks it's convincing enough to go to the next stage. I'm not. It's just an opinion.
I think Ryan would probably say yes, but maybe not with us, but maybe he can.
I mean, if there's anyone there out in listening to us who has an opinion, please feel free to express your opinion in the chat or in the questions and answers section. And if you've got any questions too, please put them forward, and I'll hand back to Chris as the chair.
I know it's good discussion, and I think you make a valid point. I think definitely, I mean, if I can be brutal, there isn't this paper doesn't give us enough to make this common treatment, like you've already sort of indicated with the question, and around whether or not there's enough data here for moving forward. I think, and we've also got a comment from Brendan, probably goes both ways, doesn't rule out that it doesn't work either. And I think that's probably fair enough. I think there's probably, we know that the theory holds up to some degree. We know that GABA, the GABA baclofen works on the GABA-A receptors. We know that GHB works on GABA receptors, so it's not outrageous. And we've got a trial that's shown some, faint signs of hope, as you say, with some questionable design flaws that probably need to be ironed out with a better study that perhaps picks patients a bit better and is a bit more clear about the regimenting the standard of care and trying to ensure follow-up on both sides of the trial. I think the other thing that was interesting was just shows you how important to marry up each side of the trial is by getting side effects on both sides. Even if you're not doing something to people, it's important to still gauge side effects or just, ask them the same questionnaires so that therefore that if something does or doesn't happen, whether or not that is something that's relatable to the drug you're using, or whether it's something else entirely, like you say, and whether or not it's just symptoms related to they'd all gone through a withdrawal, so whether or not it was just a hang up from the withdrawal or something like that.
There's two great questions there from Lisa. I don't know if you can see them there.
I can now. Sorry, I was on the wrong chat. Are grams of GHB equivalent to mils?
No.
Oh. Nadine Nezar would like to answer this question live. Says now. Would you like to answer this question live?
Well, but Ryan, can you answer the question?
I'm Googling the specific gravity of GHB to see what it,
No, I mean, it's not, there's not many things. There's not many things that are 1 gram equals 1 mil. Like, doesn't quite work like that.
I think it just depends on the purity, right? But usually it's about half, I guess, or maybe 2/3. So 3 mils, 2 grams, that kind of order.
And did they wean the participants from the 60 milligrams of Baclofen? I would hope. Brian, any comment on that?
There's nothing in there about that. So there's no discussion about what happens afterwards. There's no discussion about whether it was stage supply or anything like that. So,
that's a shame.
Well, at least not that I like reading. Yeah.
Because we use Baclofen a lot even for the withdrawal phase, and then the question of how to taper it off is still a bit up in the air as to how best to do that. So it's a shame that you can kind of collect that. Yeah. And
that's an important limitation of Baclofen, is the Baclofen dependent syndrome, which is not comfortable for people at all, and needs to be carefully answered in whatever trial comes next.
yeah.
You know, we know that methamphetamine works for cocaine use disorder, but you know, do we want to pursue that as a line of treatment? So I think that needs to be thought through quite carefully, really.
Yeah, I think it's what turns people off using Baclofen quite a lot. Admittedly, I think the worst outcomes, and you can correct me if I'm wrong, with Baclofen withdrawal tend to be in people who've got intrathecal Baclofen, but that's not to say that oral Baclofen can't have a withdrawal syndrome. And yes, I think at the moment, given the number of alternatives for alcohol use disorder, Baclofen's now probably dropped down to about 5th in terms of whether or not to use it. And in fact, there's some even saying not to bother, I've noticed recently. But then there's other people arguing that perhaps we're not using it in high enough doses. So at least with this study, they got it up to 60, which I think is pretty good, personally. But thank you, Lisa, for both of those questions. And I don't know about the stage supply, but again, I think that's another important design concept. You know, we do stage supply for a lot of our treatments. So again, this is probably one where perhaps not needed daily, but probably a couple of times a week would be sensible, just given the potential risks of it as well. But it sounded like they didn't have any overdoses or anything like that, which is pleasing. All right. Any other questions or comments about this this journal? Otherwise, we might.
It's interesting it got published in CNS Drugs, which suggests there is interest because there is no treatment at all. So
yeah, and I think, I mean, it's the sort of thing that, yeah. Oh, sorry. Brendan said here, original paper shows a 2-week taper. Okay, that was about the amount of time it got up to get them up onto the treatment. So, yeah, I think that there's a lot of interest in this. It's obviously an emerging area. People are more and more interested in GHB. Maybe at some point, Baclofen will be the sole treatment for withdrawal and longer term. I don't know, but still a lot to look at in the space.
agree.
All right. Well, thanks again. Join with me in thanking Dr. Ryan Cocker, our resident psychiatrist. And thanks everyone for signing on to this week. Next week, we'll have David St. Quintin, who will be talking about motivational interviewing and trauma in the AOD space, which should also be very interesting and engaging. So look forward to seeing you all then.
Thanks, Ryan. That's really great work. Thank you.
Thanks, Ryan.